and I'm the state coordinator for Asami, India. And today we are doing our talk or meeting on the basics of Ilizarov and limb reconstruction. And so I hand over to Dr. Rajat for the rest of the meeting, and I'll be coordinating in between. So Dr. Rajat sir,
Hello.
he's the president of Asami, India, and next he'll be speaking. Thank you.
Yeah, Jaswinder, I'm audible.
Yes, sir. You are audible, sir.
Yeah. So, hello everyone, and welcome to the new series of Asami India. We'll be doing in this. We'll be doing in this year. Last year we did the master series, but in most of the conferences and workshops, we found out that out of 100 delegates, if they are there in a workshop or a conference, only 5 or 6 are doing Ilizarov. And most of the youngsters, they keep on asking where to read or study the basics of Ilizarov. So we came up with this new session of the basics of Ilizarov. Every month we'll be covering the very basic topics which are needed to start to operate with Ilizarov or deformity correction or with the other fixators like LRS and all. So let's start with, and I welcome all of our speakers. And Shamsul and Jaswinder, please introduce the speakers and let's start the session.
So Dr. Shamsul, will you introduce the speakers, please?
Yeah, we have to introduce the speakers. You can take over. So we request Dr. Jaswinder to coordinate the meeting. So Jaswinder would like to introduce the speakers and start the program. You can just take names of the speakers one by one. Jaswinder.
Yeah, so Dr. Shamsul Hoda will be talking on the instrumentation part. Dr. Ritesh Pandey from Patna AIIMS will be talking on the safe zones. And after that, we have case discussions. And for the case discussions, Dr. John Mukhopadhaya sir from Patna is there. Dr. Ritesh Runu sir from IGMS Patna is there. And Dr. Ashutosh also from IGMS Patna is there. So may we start with our basic talk. The first talk is by Dr. Shamsul Hoda on instrumentation.
Thanks a lot, Dr. Jaswinder. So, as Ritesh said, we are doing this webinar after a long time. This is the need of time so that we shall start the talks on basic series. Is my screen visible, sir?
Yes, yes.
Thanks, sir. Thanks a lot, everybody, again. So, we are starting our webinar series. Normally, what we are seeing that in our all physical talks, our basic talks are for 8 to 10 minutes only. So we'll be doing the series one by one, starting from Bihar, then Tamil Nadu, and then Rajasthan. So that we must be having the basic talks of around 15 to 20 minutes. All the youngsters can see on YouTube and Asami India YouTube and also TV. So today we are starting with basics. I'm talking on the very important part, Ilizarov instrumentation. So Ilizarov instrumentation is like a Lego, and the little people in it are our patients, and we have enormous potential of use. So the possibilities are only limited by your imagination. We can do endless number of possibilities, constructs, and possibilities in all the parts, upper limb, lower limb, everywhere you can do. With the Ilizarov, you have a good sound knowledge of Ilizarov instrumentation. So you can see we have infinite uses starting from different severe deformities, the neck, up the back, as research doing on the spine, also severe knee and deformities with then we can like a Milwaukee brace and different growth regulation problem like limb lengthening, traumatology, pelvic surgery, angiology, hand and foot surgery, veterinary surgery, organ preserving, osteoplastic surgery, treatment of acute and chronic osteomyelitis, cranioplasty, maxillofacial, bone oncology, vertebral surgery, general orthopedics, and so many else. So starting with the basic instrumentation, we can divide the elements into two parts, the primary or the transosseous elements and the secondary or the exosseous elements. In the primary, the elements are the one that connect bone to the frame, that are the wires that can be plain or relief, and the shank spins. So these are the components that connect the bone to the frame. These are the connecting parts. Then we have the secondary or the extra osseous elements like one that we secure wire to frame of apparatus like the fixation wire fixation bolts. There can be different types. Then we have supporting like rings, arches, plates, posts. Then cutting elements like threaded rods, telescopic rods, ratchet tubes. Then assembly like nuts, bolts, socket. Then sliding like buckles, washers, and those things. Then we have the surgical instruments like the osteotomes, power drills, mallets, plier, coltome, etc. Starting with the wires, these are the transfixion wires that transfix through the bone and connect to the elements at the rings. And these are the correct bolts to the supporting of the frame. This can be of two diameters, like 1.5 for regular in upper extremities and critics, and then we have basics of 1.8 for the lower extremities. We have more that is customized and can be usable. Wire stiffness is proportional to 4th power of diameter. And the point are two types like bayonet point and trocar point. The bayonet point shows that both cortical and Tesla spores can be used for the bore. Makes hole of diameter slightly larger than wire, causing less friction. Hence, better penetration power has with less heating. And for the trocar point that we use in the meta epiphyseal region, since less penetrating power there, better in bone. You can see in the diagram. This is a trocar point. This is the bayonet point. The bayonet point is a little longer. This sharper just like a simple K wire. So these are different uses. Bayonet can be used everywhere. Trocar can be used in the metaphyseal part, for the soft bones. Then we have the plain and the olive wires. Olive wires can be the Russian wires with a small build. You can have the Russian, like the rounded, or the American, the blunt with the part. You can see like this. It is more the American part can be used more in the compression, like different. You can see in the diagram. You can do as use olives and continuous olives for like CC screws. CC screws we are using from medial or lateral only, and olive wires you can use multi-direction in all these fractures. This give very good compression for the fractures for different transportation, different deviation. So the directional bar upward cortical bone to pull and stabilize the bone segment. Olive types we have Russian and American. Russian type of spherical olive, and American have shapes like strawberry, flat end, kissing bone, tapered end, touching skin. The use is for deformity correction, compression of bone fragments, maintain fracture reduction. Traction element pull bone in the desired direction. You can see in the proximal tibia part, structural part, we can have given multiple leaves and fit part for a very good reduction and destruction also. Then we have the half pins. Half pins are the sand pin, occasionally preferable to wires. The risk of neurovascular compromise are present. You can just use from one side only. We have threaded pins, 4 to 6 diameters. We need pre-drilling, and we can use 5 millimeter or 6 millimeter in adults and 2.5 to 4.5 millimeter in children. And we can use for hybrid fixation or in Ilizarov or in LRS to stabilize fixation. Then also we have HA coated pins for the osteoporotic bone. These are the different uses in the thigh. You can see the thigh frame, the femur frame, you can have used shank pin. For the beginners, shank pin is always good. For within the tibia, you can apply wires and shank pins. So because in medial parts is dangerous, you can start with shank pin. These are different diameters, small threaded, long threaded, and for the cancellous also. And these are the HA coated. When the bone is osteoporotic, you can use these ones. For the pin coatings, we have different coatings like the hydroxyapatite coating versus titanium versus uncoated. So in India, we are usually using HA coated only. These are with superior retention of the extraction torque for the osteoporotic bones. Has there is decreased risk of an infection. 13x higher extraction torque versus uncoated. 2x 2 times higher extraction torque versus titanium. Extraction torque and extraction torque equal with HA coated pins. Highly considered HA pins for the extended use or for definitive fracture care. Possible future coatings are bisphosphonate and antibiotic coated. We are waiting for the antibiotic coated just like nails. These are the different drill bits we are using for the different surgeries. In Ilizarov, we use 4.8 millimeter for the 5 or 6 millimeter shine screws. And then we use 3.2 millimeter for 3.5 or 4.5 millimeter shine screws. Then we have the sleeves for the drill bits of different sizes, for the K-wires, for the drill guides, for the screw guide. Suppose we are going for the medial side or the danger zone, we have to avoid the skin laceration, soft tissue laceration, neurovascular injury. You can, if you're going for the medial side, you can just give a small incision, penetrate with the artery, and you use the sleeves for a safe incision of the drill bits from any side, either you're using Ilizarov or LRS. These are the K-wire guide with the inner diameter of 2 millimeter and increase the precision. You can guide the control of the direction also with this if you want to put an oblique wire. Then we come to the rings. We usually have the full rings, complete rings. that had no joints in between. We were using in a very long back, but not in use. So we are using two half rings to connect and make one ring. These are the most commonly used half rings. Then we have the 5x8 rings that we can use in the distal femur, proximal tibia, where we can have a joint of range of motions. Then we have omega rings for the shoulder. If you don't have the 5x8 rings and you want to make one, you can just make two half rings to make one 5x8 ring like this. Or similarly, you can use one half ring and use two curve plates to make an omega rings. So these are the custom made. These are Johar technology you can use if you don't have one. And different mates of the rings. We have the very common stainless steel rings that we usually apply in all the parts. Then we have the aluminium you can use in the forearm or the pediatric. On the elbow region, we want a lighter weight. Then we have the carbon frame that we can use in different parts or even the HVs or tech supports. These are different colors and different weights. Regarding the full rings, again, we can say that because of the difficulties in the application, whole rings were removed from standard reserve sets now. We are using the supports. We can use one piece and fabricated. So a prefabricated support we really use for more comfortable, although it takes longer to assemble. Regarding the half rings, the half rings has multiple holes for attachments. It has a mechanical resistance of greater than 90 kg per square millimeter, and the sizes vary from 80 to 240 millimeter inner diameter. These are usually 5 millimeters thick, and the hole diameter is around 8 millimeter each. Space between the holes are 4 millimeter, and the ends bend to ledges to attach another half of the ring in the same plane to make complete ring. So these are the ledges you can see on each side of the rings. You just match them so that make a linear ring to connect both two half rings. So two half rings make one full rings like this. Again, for the ledges, the ledges should match like this, just like in shaken position, so that it becomes a linear angle. You should apply in the opposite direction, not like this. This is wrong. You should be very, very careful for the beginners for making these rings. This is very important. The ledges will match like this. And with the half rings, we can make variation of assembly, numerous assembly as per use, as needed. You can use with arches, you can with rings. You can see different combination that we have made. You can use wires, sand skins in different directions, then post, male post, female post, anchor cubes. So these are different possibilities for the half rings that you can use in different direction, even with oblique rings also, oblique pins also. For the 5x8 rings, you can see the diagram. If you use a full ring here in the knee, you won't get a full range of motion. You gotta do a good laser surgery, good transport, because the ring has to be there for around 1 to 2 years, sometimes 6 months. But if you keep the stiff knee, you will end up another problem. You can make a good transport knee. You are saving the limbs, but you're having a stiff knee or a stiff distal femur part. So we can use this for the upper part, connect with the straight rods or hinges, and the sizes differ from 130 to 180 millimeter inner diameter. The advantage is that it facilitates joint movements. Wound dressing is very easy using mycotinous flap, large deep incision, as in compartment syndrome. The disadvantage is that it can't bear load of tension wires. So load bearing is less in this. So you have to attach more rods. Be very careful with this. Can use only with full rings. The use around distal humerus, proximal tibia, distal femurs may be made by two rings bolted together to form one 5x8 rings. You can see in knee, in the elbow. You can also use in the distal femur also. So usually for the tibia, I use this 5x8 rings in the proximal part, so the patient had full range of motion with this. Regarding the omega rings, these are very lesser used, but can be very well used in the around shoulder, in the proximal part of the around the head of the humerus, where 5x8 ring impinges. So the sizes available are 120, 130, 140. It can be made by 3-hole curved plate at each end of the 5x8 rings. Then we come to the foot plate. These are the different types of foot plate, the carbon full plate, or you can have a decimate plate like this, or you can use a half ring and attach two separate plates here. These are very important if you have a to avoid equinus deformity, to correct equinus deformity, to maintain the foot length for this different wounds. So for deformity correction, maintaining equinus, avoiding equinus is a very important role for the foot deformity corrections of different levels. This can be used custom made, Jugaad made, or the carbon frame. Then we have the arches. You can see this is a custom arch. This is the Russian arch, and the above part, this is Italian arch. Usually in India, we have different types of different force Italian arch. These are the simple hole ones. These are the sliding holes. You can apply the bolts anywhere in this over here. So these are the large, heavy curved plates. Use this proximal femur fixation. Size goes from 1/4 to 1/3 of a circle. Sets are small and large. Types we have Russian that varies from 82 to 60 millimeter in inner diameter. Used in upper thigh for vas in the proximal femur. Then we have Italian that is 90 to 120. Small and large fixed half pins in multiple planes using proximal femur and humerus. Then we have these oblique supports that connect the arches with the rings. Okay. So we should use this oblique support very meticulously. If you want to just fix, you can use oblique support. If you want to have distraction transport, you can use hinges with the ruts. These are the different connections you can see with the arches and the oblique support, different types you can use. Similarly, in the clinical part, you can see is the proximal femur. We have used arches, then oblique support. If you want more distance, you can use ruts also. So these are different types of uses. You can connect it directly with the rings. If you want to have more distance or do traction or compression, we have to use a accordion in this case. This is case of infected non-union. So I applied a rod, we do accordion with this. So these are different uses of arches and oblique support. This is a typical diagram of an arch and oblique support. This is a diagrammatical use in the femur. Similar photographs for this femur part. You can use two arches like this. Then we have the bolts and the nuts. The bolts are like this. These are 6 millimeter diameter. You can have 10 threads in 1 centimeter. So one full turn moves a 1 nut 1 meter. People are often confused which is a nut, which is a bolt. So these are the bolts and these are the nuts. Nuts are holes. So these are 6 millimeter diameters. 10 threads in 1 centimeter. These are different. 1 centimeter has 10 threads. And the diameter and threads of the bolts are identical with the connecting nuts. Length is around 10, 16, 20, 30, 4 millimeter thick. Bolts and nuts fit for around 10 millimeter wrench. So you should always have a 10 millimeter wrench with you when you're doing the surgery, and after surgery you have to connect and you have to guide the patient. So keep your wrenches ready in your OT or the dressing room always. So now the nuts. So nuts are thick around 3, 5, and 6 millimeters. 3 millimeters lock nuts on hinges. 5 millimeters to stabilize or falls of frames. 6 millimeter have connecting nuts where compression and distraction is required. These are the 10 millimeter nut. These are the square nut. These are knurled insert nut for a good hold. These are scorn rod, but you can just apply the wrench in position. You can use the square nut for corded area. Then we have the fixation bolts used to secure wires. This can be around 6 millimeter diameter, 18 millimeter. The bolt heads are hexagonal, or can be flat or rounded surface, and can be 6 millimeter thick. So we have bolts for around 3 varieties: cannulated, grooves, slotted, or culprit taper head. So these are the cannulated bolt, where the wire goes in through and through the bolt. And this is a slotted one. So this is the cannulated one. It is oppositely written. So this is the cannulated one. This is the slotted one. Okay. So in cannulated, the wire passes on the center. The slotted, we have on the side on the you can passes from here. And this is the tapered. This is another one. You can just put for the nuts. Then we have the washers. Washers are used when we are passing a wire and the wire doesn't goes along with the ring. There's a gap. We can use washer. We should not pull back the wire to the ring. We just we should use washers over here. So we can apply the wire in the direction of the ring, not giving any pressure, so that it may cause skin impingement or can cause pain. So these are the plain, thick and thin wire. These are the wires to the slot. These are the spherical and conical wire. The spherical and conical wire can be used for if you want to apply the plates, not the ring plates in different direction for the attachments. These are very important. So we can use the wires, the slotted boards in different directions. You can change the direction. It's going to increase the gap. If you want to apply one wire over here, then you can apply one wire in the upper level. You can change the different level also. You can change the directions also. We have root washers. Then we have paired spherical washers to compensate angulation between the rings and the threaded rods. You can use in pairs to fashion elements at an angle. If you are using a carbon frame or an aluminum frame, you should use a washer always. Then have the rods. We have the usual threaded rods that connect. That we have the connectors between the supporting rings and plates. You can use a traction device, the transport device, the leathering device for gradual transport. Length comes from 30 to 400 millimeters. If you are using a long threaded rod, you can use a false ring in between. This is the usual assembly of the rod. So the rods means are very important assembly of the Ilizarov ring. These are different parts. You can connect with the rods. You can connect with this distractors also. The rods can be used plain or the distractors also. Then we have the slotted threaded rods. If you want to do an internal transport of the bone, we are not doing external transport. Then you slotted rod. The rods have slots in between. You can apply the cushion wires tighten it and gradually distract it. So you can have a slow distraction from here to here in these cases. You can do a transfer transport. You can do a vertical transport, oblique transport. These are advanced techniques to apply tension force for interfragmentary compression also for bone transpression. And now even for the soft tissue transportation, we can also do it like this. This is a technique. Then we have the telescopic rods in the tube. These are long hollow tubes. They have a threaded component at one end, perpendicular locking bolt at other end. At the base accommodates 10 millimeter open and range. For long distance spanning, we are using normally the structure for the long distance, like 50 to 200 millimeter. When the rods will be bent, it won't be giving a strong assembly. So within when you start the transport, we start with the threaded rod. When we go long way, we apply either a false ring or we can use the replace with the distractors. So that gives a very stable construct. There's no deviation, and the Regenerate works very well with this. For landing, it allows frame expansion from within. It's very easy for the patient. You just click, and you can tell the patient for this. And it facilitates execution and control of lengthening, slotted marking in millimeter to access the amount of lengthening and shortening. Then we have the post. Then we have the male post and the female post. The male post has a threaded rod coming out through the tail. This is the male post. The female post has tapered bolt adjacent. Then the singular post can use a hinge. You can just use these ones. Singular male and female post. Connect with the nut and bolt here. This is the hinge at any other point like this. So singular post can use a hinge. These are asymmetrical with flat rounded side. When a pair of single hole posts bolted together form hinge with two arms at the same plane. You can use that civil for the ring rotation, points for the pushing or pulling rings. The post used for multiple functions like fixation points for wire of the plane of the ring, attachment points for the slotted threaded rods for bone transport. Three posts connected together at the right angle for universal hinge. So here you can see that you can use posts for using wire at a different level, upper level or lower level. You can use oblique wires with the post. You can use multi-directional. You can use traction with this. You can use So we can use three male female to use make a universal hinge. You can use this for drop wires or drop pins. So usually the Ilizarov, you are attaching one wire, so these are drop wires. Then we have the rancho cubes. If you are applying shank spins, you have to do rancho cubes. So these are the different rancho cubes: 1 hole, 3 hole, 2, 4 hole. So we can apply this rancho cubes to apply shank spin at different levels. So you can just use one ring over here, or you can then you can apply one pin over here, one pin at upper level, one pin at lower level. These are the rancho cubes. So arrange to just accommodate the shank spin clamps. So we have horizontal and oblique holes, rancho cubes for the shank spins. Then at the hinge, you can see this is the male hinge, the female hinge that you can make a simple joint. You can use the universal joint. This is the relative universal joint. The universal joints moves in all directions, and the male female moves in one direction only. So if you're just doing the simple movement at the knee joint or hip joint or even at the ankle joint, you can use a male female. But if you are doing a complex deformity correction like club foot, you have to use different universal joints in these planes. We have to correct varus also. We have to correct cavus also. We have to correct equinus also. So these are different uses. So works as joints for deformity correction, opening wedge, distraction, compression, translation, derotation, works as fulcrum. So make by joining posts or universal joints, one male and one female use connected to make the complete joint. So here you can see this is a universal joint. Yeah. This area this is a universal joint. Here, as we said in the earlier page, one male, one female, and again one male. You can use a universal joint like this. You can move in all 360 directions, all the directions like this. You can use all the directions. So these are different different positions of the hinges. So this is the one hinge built with 2 male half rings, hinge built with 2 male posts, hinge with 2 female half rings, hinge made with 2 female posts, made with 1 male and 1 female, and with a male and 1 female. So these are the different possibilities of the hinges. You can have multiple use of this. So these are different uses of the hinges dramatically. for different points. For the deformity correction, it is a very important role for the making it as a distractor also, as for the correction also. Then we have the wire fixation buckle that is a very less use. It is optimized for Ilizarov wire fixation device tagged for attachment of the threaded rod, fits over and can slide along the ring of the plate. You can just apply here. You can apply the wires over here and attaching it. You don't have a space for the ranges. So these are very less used. So we're not discussing it more. Plates has a very important role. It can be used if you want a parallel distracted device. If you're not fitting the we have less space, you can use plates over here. You can use plates in different directions, different uses for the oblique wires, oblique planes, for the distraction. These are in different sizes. This can be plain or threaded. So length varies from 2 to 14 holes. Use our wire attachment points like lateral distraction. Supporting element in push configuration for simultaneous angulation and translation of ring clusters. Short plates are used to increase diameter of the small rings or foot plates. Then we have paddles that used for the attachment. These are the paddles for the one mode that increase diameter of the small rings or the foot plates. Then we have the twisted plates. If you have a ring and you want to apply a plate or a rod in a different direction, you can use twisted plates over here. To rotate plane of the rotation, we can just change the degree of fixation to 90 degrees. You can swivel with this also. Use with single hole plate for distraction of another convex side of deformity. Provide fixed distance between rings. The correction of angle. I use this twisted plate in the clubfoot assembly very well. We'll switch some diagram. Then we have sockets. The length is about 20 to 40 millimeters and use the interconnect. These are interconnection. If you have two small rods, you can just use a socket and make it a long rod. You can use the spacer also to raise the point of fixation above with the ring. To connect or disconnect the threaded rod to the ring to perform a collectomy. You can connect. You can just disassemble this, do collectomy, and again assemble with this. These are different use to increase the diameter of the rod. Use a spacer and to disconnect as in for collectomy also. Or even to attach hardware to the carotid point, or when you are using tensionometer, you don't have a space. You can also use this for compression also. The short sockets use an extra long nut to get range due to carding hardware. Then we have bushings available in two sizes. Inner diameter of bushings larger than outer diameter of threaded rod. Use a sliding assembly to move the components along the threaded rod. At fat pressure to elevate pieces of hardware of ring or plate. These are the bushings of a different use. Less commonly, but used in many places also. Now we have a very important part, the wire tensioner. So these are the basic tensioner that we have been using from the Professor Ilizarov time. We have a spring load tensioner or the manual tensioner. So this is a manual tensioner, or this is the spring load tensioner. We first talk about the manual tensioner. It uses a large wire nut on the threaded rod bolted to the wire. If no solid contact in between the jaws or the tension bar, we can use a plate or socket. We just adjust this part of the ring, tighten the wire with here, and just tighten from here. So this is a very important part. This is the spring load. We connect from here like this. And the full pin has to be adjusted, fixed very well to the ring. Then we can give a tension of around 120 degrees. This is the new generation range type tensioner. Symbol like a range. I've been using this very. This is very easy to use. We just tighten and give rotation. Then you can use it. So these are available. Then another we have very important part, collectomy and osteotomy. Osteotomy you use regularly for the osteotomy, and these are the collectomes. We have the one pointed end here. So this is the inner part. We use it for the outer part to save the universal structures, and then we gradually do after the drill bit use. We can use this for different part of collectomy. Different parts. The sizes are 3, 5, 7, and 9 millimeters. So these are very important part for the collectomy. And then we have the mallet, like the hammer, we use for the collectomy or the osteotomy. So in short, these are the different parts of the Ilizarov apparatus. The rings, the arches, different parts. You must have all this ready in your table when you're doing any surgery. These are the basic arrangement we can do with the Ilizarov instrumentation. The basic support of the tibia and the femur for the deformity. These are the different parts, different configurations. We should use with the Ilizarov instrumentation in the upper limb. These are the humerus, arm, distal humerus, the elbow, olecranon, elbow joint, the forearm, the wrist, the femur, knee joint, tibia configurations for different parts and different fracture, different deviations. Should have a picture of this. These are the different foot and ankle for different foot and ankle fixation or the deformity correction. These are for different transport arrangements of the femur. These are can be used like with the hinges or the plates for the displacement. These are the newer devices supports, so that's a separate chapter. So you should keep this reserve box with you. We welcome you to become a member of Asami India. Thank you. Thanks everybody. Thanks a lot.
Yeah, thank you, Dr. Shamsul. That was a very nice and very detailed talk about all the instrumentation. So can we have some questions now from Dr. Shamsul, if there are any?
So Shamsul, I have like in your operation theater,
Yes,
do
sir.
you have all this instrumentation available? Or because many times I've seen that for cases when you are starting, you don't have the full set, and you ask from the vendor to get to do the case, and many times the basic components are missing, or the sizes are not that appropriate. So what do? You keep your whole set, or you get from the vendor and see that all the basic instruments are there?
Thanks, Ritesh, sir. This is actually a very important point. Initially, we used to ask for the vendors, but now I keep two sets ready in my OT. One is completely sterilized, very important, so that you never miss a point. If you have to apply oblique support, you have everything in your OT, sir. So there is a customer box from the vendor, just like we have a box of a nail or plate. So the box is very important. One level we have the instrumentations, everything, and one level we have the rings. So I usually keep a box ready with me in all OTs, sir.
Okay. And one of my advices to the youngsters that usually we always keep the Ilizarov set ready with autoclave, because many times in my practice also I've seen that I started with a plate, let's say a fracture of a proximal tibia or a distal tibia, in which I initially my planning was there that I will be doing a plating, but seeing the swelling and the skin condition and the amount of condition, many times we have to change it to Ilizarov. So if your Ilizarov set is autoclave and ready, then it's become very handy. Otherwise, you have to go for plating anyhow, and sometimes you get messed up. So it's better you have always a set autoclaved and handy, just in case you need it. Okay, I think Jaswinder, if there's no other question, let's continue with the other talk.
Yeah, so the next talk is by Dr. Ritesh Pandey from AIIMS, and he's speaking on the safe zones. So may I ask Dr. Ritesh to start his talk?
Yeah, thanks, Dr. Jaswinder. So,
Please share your screen, Dr.
yeah,
Ritesh.
yes, I'm doing that. So,
Still not visible.
is it visible now?
No, not yet.
In the meantime, you can send me also, Ritesh.
Is there some problem, Dr. Ritesh?
No, I'm trying to share it. Is it visible now? I have opened the PPT.
No, it's not visible here. You can, have you closed and shared it again after, I mean, if you are having a problem. Dr. Shamsul, can you please help Dr. Ritesh?
So,
If there is a problem, we can go to the case presentations otherwise.
yeah,
Yes,
I'm-
actually, I'm clicking this share button and then
nothing is happening.
it's not opening up actually. Even after clicking the share, I'm getting open the system settings.
Maybe you need to log out and log in again sometime.
Dr. Shamsul, can you please help me?
Yeah, I will try to log in again. I think we can proceed with the next speaker till then.
So,
So there is a question from somebody about do you use it for closed fractures, the Ilizarov? I think so. Both in pylon and proximal tibial fractures, where there's a lot of swelling, there's a role for the Ilizarov fixator. They don't have to be open fractures. Yeah. In fact, some years ago, before the lock plates came in, there were a number of studies showing that the Ilizarov fixator was as good as plating in some of these situations. So I think, so do you want me to do my cases then? If Jaswinder,
sir,
should I start with my case then? If there's no,
yeah. So we can, because I think Ritesh is having some problem in sharing his screen. So we can start with the case discussion.
yeah. So I'll finish quickly because I have to leave at around 9:50.
Yeah, sure, sir. Sir, but just is everyone able to hear Dr. John's voice loud
Can
and
you
clear?
hear me?
Yes, sir, it's okay, sir.
Yeah. Okay.
Yeah, okay. Right.
Okay. So I'm just going to share my screen. And are you still sharing your screen, Ritesh?
No,
Ritesh,
sir. No, sir. I'm not trying to share it.
Okay, so then I'll start.
Yes.
Yeah, is that okay?
well, sir.
Okay, so I've got two cases. One is a relatively short one, although it just does show you some of the problems you can have. And this is a 6-year-old child who presented with chronic discharging sinuses. She had a history of infection 9 months earlier, where she was treated with antibiotics early and then followed by drainage and drilling. You can see the number of drill holes in this sequestrated fragment here. And so this is what she came to us with. And so obviously the question was to remove the sequestrum debride, and we did that. So, this is 6 months later. She has this problem. She has a gap. Now the infection is controlled and we have to deal with this problem. So I think the fibular graft is something we used a lot in these children with success in some of them and failures in some of them. And so we felt that the locking plates had just about come into the reckoning. And so we felt if we combined the stability of a locking plate with the fibular graft, it would help us getting healing more easily. So that's what we did. So we used this locking plate. There was the fibular graft, and we put it down and also put iliac crest graft, cancellous graft at the two ends. to help with the union. Now, unfortunately, this caused the infection to flare up again, and we ended up having to take out everything. So that was, you can see that the fibula is kind of disappearing, but you can see how where we had taken the fibula from is now regrowing, okay? So that is something we see in kids very often. The fibula that you take out, as long as you leave the periosteum, you get new fibula forming there. So now we had this recrudescence of the infection with the plate there. So we had to go back and re-debride. And this time we decided on a different method. We used the Ilizarov fixator. So you can see we've got one ring beyond the ankle, two rings on the tibia and one ring near the knee. And then we did the corticotomy in the distal part. Proximal segment is a small segment, and we have a large gap there. And then we transported it from distal to proximal, got the docking compressed at the docking site, and that was her at this time. We then, once the fracture had healed, we took out the fixator. So at this stage, the fracture appears to have healed. It was 10 months from the original frame. We put in the frame. It took almost 2.5, 3 months for the transport and another 4 to 6 months for the bone to heal up adequately to remove the fixator. And this was the 20-month follow-up. You can see how it has healed up. The regenerate has formed very well. Where we've got it to unite because the bone was a bit thin, it's still a bit thin. Again, you can see how the fibula has reformed, and she's got a fairly good range of motion with full flexion and extension and equal limbs at this stage. So this is a relatively simple case of a bone transport where you had infection, pathological fracture, bone gap, and then we tried a fibula graft with the plate, and that failed. And then we had to resort to the Ilizarov to do a bone transport and get healing of both the infection and the fracture. So that is the first case. And then we have a slightly more complicated case. This is a 12-year-old girl. She had osteomyelitis of the distal femur at the age of 6 years. She had pathological fracture with bone loss and had multiple previous surgeries with multiple debridements. She had fibula graft, non-vascular, done once. That failed. That caused a recrudescence of infection. And this is what she came with infection. So that was the situation when she first presented to us at the age of 12. Okay, and the knee was already stiff. There was like just a jog of movement at this stage. You can see that there's a little bit of flexion there, but otherwise the knee was stiff. So we first went in, we debrided it, we kept her in a cast, and we sent her home, and she didn't come back till 5 years down the line with this kind of X-ray, totally stiff knee, a large gap in the tibia, and a huge shortening. Where's the, sorry, I seem to have missed the clinical picture there. She had a shortening of almost 14 centimeters. So her limb, which was flail with the non-union, reached about halfway down her leg. So it was mid-calf that it reached, and that was the situation that we had to deal with. So what would anyone do at this stage? Anyone from the panel? Rajat?
Sir, we will be, I think as a standard, we will be first have to do the lengthening and try to create decrease the bone defect and do as much lengthening as possible. And while lengthening, we have to see that the tip of the bony end goes in the center, because otherwise there will be another deformity created.
So we did that. We did a transport, and we also lengthened the tibia because the knee was stiff, and we corrected the deformity, the flexion deformity at the knee, and we got it to dock. We bone grafted it at the docking area, but unfortunately, this did not unite. And I think this is what she came to us with. At this stage, you can see the tibia is lengthened, that has healed, but the femur fracture has not healed. And this is, sorry, the clinical picture at this stage, showing that it's a flail limb from the non-union site. The knee is totally stiff, and her leg reaches just halfway to the calf on the other side. So now what do we do?
Sir, you did the lengthening of the femur also.
Yes, we did transport on the femur. We got it
Okay.
to dock, and then we lengthened the tibia.
Okay.
So because the knee was stiff, we felt we could get some of the lengthening on the tibia. And we hoped that the fracture would unite, but it didn't. And we are stuck with this situation now. So now this is where we decided to forget about the knee. Because it was already grossly stiff. The lock plates had just about come in at that time. You can see this is 2005 at the stage. And we did this long plate fixation, okay, with bone grafting, docking the distal femur with the proximal femur. And then we put a Ilizarov over this part and then lengthen the tibia distally. So that's where we did the corticotomy on the tibia, which was a diaphyseal corticotomy. And we lengthened from there. That was the frame at that stage. We gradually lengthened it. You can see that we lengthened almost 9 centimeters by the end of it. And this formed nicely, and we could get the fracture to also heal with the lock plate and bone, with good stability and bone graft. So that's what was the maximum length we could safely get at that stage. That was her in the ring, waiting for the regenerate to solidify. And then we took out the ring, and that was her. So you can see how it's nicely formed. Obviously, the tibia is very long, the femur is really short, and the knee is would be somewhere halfway up the thigh. That is follow-up, more recent follow-up. This is as late as 2019. So this is now 12-year follow-up. This is her at this stage. Not great, but at least she's able to walk. You can see this is her gait at the stage when, yeah. So she does walk with a limp, but she's able to walk, and she's managing with this. She's got a foot deformity, which I said we need to correct, but she's managing on that, and she's quite happy with that. But we could lengthen her a bit more, but when she wants to. So that is where we are at this time. At least we were able to get her to be able to walk independently without support. Okay, and she can also manage to sit on the floor. Sorry, I think this is some other patient. I'm sorry about that, because her knee is totally stiff. This is another patient. This is the next patient. So we'll stop there. That was the next patient that we were dealing with. So I'll stop sharing, and we'll take any questions that may be.
So, thank you, sir. That was a wonderful, those were two wonderful cases. And any questions, please? Anyone?
So the second case was a very innovative thing, that combining the aspects of both the plating and the Ilizarov, like fixing the fractured non-union with the plate above and doing the lengthening before. I haven't seen this type of thing, but this is very interesting. We can always follow this type of technique in cases where the patient is very much compromised, and at least the patient can walk and with pain free. So this was a very nice case, I should say.
Thank you very much, because it was like a situation where you didn't have any other option, and it's out of desperation that you create some kind of method to deal with it. So I think, and she's still managing, as she still comes for follow-up every couple of years, and she's still okay with it. She doesn't want to get anything further done at the moment, although she does have a foot deformity, which is now going into a bit of valgus, which I think we should correct, but she hasn't yet she's not yet prepared to get anything further done. She's working on that without support.
Sir, may I ask a question, sir?
Sure, sure. Dinesh.
Sir, I know different people talk different things. Sir, do you follow any this thing that how much of an acute docking in the femur you can go for and tibia you can go for in an adult patient, sir?
So I
And-
think it depends on two things, okay? Yes, you can go more in the femur, and it also depends on the condition of the soft tissue, okay? Because a lot of these chronic situations, by the time they come to, there's so much fibrous tissue that even 2 centimeters of a gap may be difficult to dock straight away. So you can do a partial docking in some of them, because otherwise you will end up with soft tissue problems. So I don't think there's a number for any particular situation, femur or tibia. It all depends on how much you can get comfortably with the soft tissue around to not cause a soft tissue compromise when you dock it. Okay, so I
Yes.
would do as much as I can do, and then I'll reduce the gap if possible, and then gradually dock it if necessary. So
Right.
that's how I would go about it. So there's no, I don't think there's a, I know people talk about 2.5 centimeters in the femur and 2.5 centimeters in the tibia and 5 centimeters in the femur, but I think the soft tissue is the more important criteria to go by.
Thank you.
Sir, may I ask a question, sir?
Sure, sure.
Sir, after doing the bone transport, as visible, the gap was not looking too much. So could we have used the fibula and bone graft and try to achieve union with like for the femur?
So she had already had 2 goes at fibula grafting.
Okay.
And so she's had everything. So we did, after that we did Ilizarov. And so before she came to us, she had already had multiple surgeries before, and all of them had failed. And then we did the Ilizarov that worked as far as some lengthening of the tibia was concerned, but the femur did not unite in spite of getting docking and transport. We got some length of the femur, but we couldn't get the fracture to unite with that because it was very difficult to get really good stability because, as you can see, her thighs were fairly sort of fat in the sense that there was a lot of redundant flesh over the thigh, and it was very difficult to get good hold on the bone to be able to dock it adequately and get good stability when we docked it.
Okay, so if there are no more questions, then we can move to the next talk. And I think Dr. John sir is attending TraumaCon at Mumbai.
Yeah. So I will leave at about another 10 minutes. I'll have to leave. So I'll just listen to
So, Dr. Ritesh, would you like to present now, or we should?
Yes, yes, I will try once if I can share my screen. Otherwise,
Yeah,
I have
it's
forwarded
visible actually. Okay. So, Dr. Ritesh works as an additional professor at AIIMS Patna, and he'll be talking on safe zones in lower limb. Can maximize.
get full screen,
Yes.
Shamsul. Yeah, that's good.
Okay. Okay. Thank you, sir. So good evening, all. I will be talking about the safe zones for wire and pin placements in the lower limb. So next slide. And these are the learning objectives to understand the relevant anatomy of the lower limb, to know the safe zones for wire and pin placement so that the complications can be avoided. So let's start with this example of this 4-year-old girl who presented to us for treatment of congenital pseudoarthrosis of tibia. And next slide, please. So for her, the pathological tissue was excised and a bone transport was planned through corticotomy in the distal tibia. Next slide. But during the process of distraction, she presented to us with a progressive deformity around the knee joint, and this was quite painful. So what is happening here? If we can see this radiograph, we can figure out that the fibula has migrated up, and this was due to transfixation of the fibula in one of the wires, and along with the process of transport, the fibula was migrating proximally. And this had already caused a foot drop in this child. Next slide. Next. Yeah. So this was another example of a 7-year-old girl with bilateral congenital talipes equinovarus, and she presented to us for correction of the deformity. Next. And she was getting it corrected with Ilizarov cream. But again, during the course of treatment, she developed this painful swelling around her heel. And this turned out to be a pseudaneurysm, most probably due to insult to the posterior tibial artery while passing one of the wires. Next. And this video gives us an idea about the extent of injury to the soft tissue if they get transfixed in the rotating wires. Next. Next slide, please. So these complications could have been avoided if one is aware about the safe zones, and we will be discussing the same in this presentation. But before that, there are some cardinal rules irrespective of the anatomical region. Next. So for example, one should enter through the more risky side, that is the side where the neurovascular structures are located, so that one can avoid injuring them during entry of the wire. The skin should be adequately released with stab incision to avoid thermal necrosis to the skin. And this is followed by blunt dissection of the soft tissues to reach the bone. And then the wire is inserted, and don't start drilling in the soft tissue. First, put your wire on the bone, reach the bone, and once you are there, then only start the process of drilling. Next. The drilling should be slow with intermittent pauses and with saline irrigation, again to prevent thermal necrosis to the bone. And once the tip of the wire is out of the opposite cortex, it should be further tapped out through the soft tissues on the opposite side. Next. So coming to the safe zones of the femur. So we need to understand what are the structures at risk in the thigh, and they are located over the anteromedial surface and the posterior surface of the femur. On the anteromedial surface, we have femoral vessels and nerves in the proximal two-third, whereas on the posterior surface, there is sciatic nerve throughout the length of the femur, and again, the femoral vessels and nerves in the distal one-third. And the thigh can be divided into these 7 levels by the help of the 6 cuts. And we can see here that the lateral surface of the femur is devoid of any neurovascular structure, and it can be considered safe for wire and pin placement throughout its length. So level 1 is the level of the femoral neck and trochanter. And as we can see here, the sciatic nerve is located down posterior, and the femoral nerves and vessels are on the anterior aspect. And due to the space constraints, usually the wires are not used in this region, but it can accommodate 2 half pins at an angle of around 30 degrees, one starting posterolaterally and directed anteromedially, and the other one starting anterolaterally and directed posteromedially. Level 2 is that of the subtrochanteric area, and this area can accommodate 1 half pin, again starting posterolaterally and directed anteromedially, and remaining posterior to the vastus lateralis muscle. Level 3 is the level of the isthmus area, and this area can usually accommodate one full ring, and hence one can go for wire placement. And as you can see here, the femoral nerves and vessels have moved medially. So a wire starting posterolaterally and directed anteromedially can be used with safety. And if using a half pin, it usually goes through the vastus lateralis muscle as the muscle becomes more bulky at this level. And so while putting the pins in this area, the knee should be kept in 90 degrees of flexion to stretch the quadriceps so that the knee range of movements are not affected in the post-operative period. Level 4 is in the mid-shaft region, and again, the same arrangement of the neurovascular structures can be seen as discussed in the previous slide, and the same configuration of wire and pins can be used here also. And although this figure is showing the use of two wires, I don't particularly use this second wire, which is going in the posterior medial direction, because it may turn risky in some patients. So only one pin of one wire is usually recommended at this level also. Level 5 is in the distal third of the femur, and all the neurovascular structures have shifted posteriorly here, and the entire medial surface, anterior surface, and lateral surface is free and available to use for the pin and wire placements. So different configurations can be used here. The level 6 is in the suprapatellar region, and a similar arrangement of neurovascular structures can be found. All of them are posterior in location, and the medial and lateral surfaces can be used with different configuration. And at this level, usually the placement below the level of the superior pole of patella is not advised, because it is considered to be an intra-articular placement and may lead to septic arthritis if there is a pin tract infection. And this paper actually discusses the use of anterior surface of the femur for putting a fixator pin. And in this cadaveric study, the authors have found that the last branch of the femoral nerve, it is located at an average distance of around 5.8 centimeters, or roughly 6 centimeters distal to the lesser trochanter. Similarly, the highest point of suprapatellar pouch is located at an average distance of around 5 centimeters from the superior pole of patella. So if we leave these two areas proximally and distally, the entire middle third of the femur is considered safe for putting the fixator pins. They also described that none of the branches of the femoral nerve has crossed this vertical line, which is joining the anterior margin of greater trochanter to the anterior margin of lateral condyle. And hence, since all the nerves were ending medial to this vertical line, the lateral surface of the femur is again considered safe for using the pins. Next. And these are the figures showing the correct placement of the pins and wires, how they should be put in. Next. And as these pins and wires, this is a video actually. So as the, yeah, it's not playing. Okay, I just wanted to show that the knee range of movements can be preserved here if you are putting the pins with by keeping the knee in 90 degrees of flexion. So here it was possible to get around 90 degree of movements at the knee joint. Next. And these are a few examples of how not to put the pins. If we can see these pins marked by the yellow arrows, they are too inferior and almost can be considered to be intra-articular. And the other pin, which is anterior, that is too much anterior, and I don't know how the surgeons have managed to put this pin. Next. This is another example. Topmost pin is quite anterior and very close to the hip joint and is in the dangerous zone where the femoral nerves and vessels are located. Next. So coming to tibia. So the leg can also be divided into the 7 zones, but due to the specific arrangement of neurovascular structures in leg, practically we can consider these 3 segments. The segment 1 extends from the knee joint to the fibular neck. Segment 2 extends from the level of fibular neck to the distal metaphyseal flare. And segment 3 extends from distal metaphyseal flare to the ankle joint. And these are the structures at risk that we need to know. Around the neck of fibula, there is the common peroneal nerve. In the anterior compartment, we have deep peroneal nerve and anterior tibial vessels, which run close to the interosseous membrane in the proximal half. But as we move distally, they start moving anteriorly. They are placed on the anterior surface of the distal tibia. And over the posterior-medial border of tibia in distal 1/3, there is posterior tibial vessels and nerves. So after seeing this arrangement of neurovascular structures, we can figure out that these 2 planes can be used throughout the length of tibia for putting a wire. The one is coronal plane, where the wire is placed parallel to the ground, starting from lateral to medial and remaining in the anterior half of the lateral surface of the tibia. The second wire is the medial face wire, where the wire is placed parallel to the medial surface of tibia, and it can be put from lateral to medial or medial to lateral. Both the techniques have been described in literature. So if we see these few sections of segment 1, we can figure out that there is the coronal wire, plane wire, which is parallel to the ground. Then we have the medial face wire. And depending on the level, if you are proximal to the fibular head, an additional wire can be placed from posterolateral directed anteromedially, and 2 to 3 half pins can also be used on anteromedial and anterolateral surface of the tibia. And if you are at the level of the fibular head, then this wire can be placed through the fibular head. And it is the same here. So mainly these 2 plane wires can be used in segment 1. Next. The same is the situation in segment 2. We can see the coronal plane wire and the medial face wire and 2 half pins here on the anteromedial surface of tibia. This is segment 2. And next. And this is segment 3, that is the distal tibia. Again, we can see there is the possibility of coronal plane wire, the medial face wire, and an additional wire can be placed through the distal fibula, starting posterolaterally and directed anteromedially. Or you can also put this wire by remaining posterior to the fibula. Next. Coming to foot, over the calcaneum, there are posterior tibial vessels and nerves, which needs to be avoided on the medial aspect of calcaneum. And the area marked by red color is considered to be the dangerous zone, because this is the area where these neurovascular structures are associated. The area marked by green is the safe zone, and a 2-wire configuration with an angle of around 30 degrees can be used in calcaneum. One can also use half pins, 2 half pins, one from lateral to medial and the other from posterior to anterior, remaining inferior to the insertion of tendo Achilles. And in talus, 1 half pin or 1 wire can be placed from lateral to medial. These are some additional configurations of wire and pin which have been described in literature for calcaneum. One can use 2 cross half pins remaining lateral and medial to the tendo Achilles, and 1 wire. And this second figure is showing the use of 2 parallel half pins, one from the lateral side, other from the medial side, along with 1 wire. And the third figure is showing how it looks in a real patient. So we can see there two half pins have been placed at an angle of 45 degrees, and one through and through wire is placed in the calcaneum. For the metacarpals, again, two wire configuration is recommended. One wire holds the medial 2 to 3 metacarpals, and the other one, the lateral 3 metacarpals. And the second picture is showing how it appears in a real patient. Next. So these are the references that I have used in preparation of this PPT, and one can refer this for more details. Next. So the learning points are, one should be aware of the safe zones so that the possible complications could be avoided. For the femur, the lateral surface is considered safe throughout its length. The anterior surface is safe in its middle third. Again, no definite area can be recommended because it depends on the height of the patient. The half pins are preferred in proximal half of the femur where there is space constraint, but in distal half, both wires and pins can be used. For tibia, the medial, anterior, and anterior half of the lateral surface are devoid of the neurovascular structures and hence are safe. The coronal plane wire and medial face wire can be used throughout the length of tibia, and half pins can be added as per the case scenario. Thank you very much.
Thank you, Dr. Ritesh Pandey. That was wonderful talk. And we have a question actually from the chat. And the question is, does safe zone refers to only neurovascular structures, or we can consider tendons and joint capsule also?
Yeah, so the most vital structures that are to be considered are the neurovascular structures. Okay, but when you are putting these wires, you need to take care of everything. Like I mentioned, in the distal femur, one should avoid putting pins too distally below the level of superior pole of patella, because it will be an intra-articular placement and that has to be avoided. But in situations where your distal fragment is very small and there is no other options, so you can still go for that. So primarily it refers to the neurovascular structures, but I can't say that you can involve the tendons and all. Like I told that if you are putting the pin through the muscle, it has to be stretched to its maximum length. So all those things needs to be considered while putting the pins. It's not only about the neurovascular structures.
So there is one more question. Do we use self-drilling shan screws, or we need to pre-drill? We need to pre-drill with a 3.2 millimeter drill bit.
Yeah, so by an rule, it is always better to pre-drill and then use the shan pins. In children or in the cancellous bones where you don't have much resistance, you can still put directly the shan pin. I have seen this technique when I was in China. They used to, they don't use the pre-drilling actually, but it cannot be advised in a cortical bone. In cancellous bone, I think that can be an option. Like you're putting a pin in calcaneum, you can directly put it with very slow drilling.
And there are chances of fracture actually if you don't pre-drill.
Yes. So
even I have experienced that once.
Yeah. So for cortical bones, absolutely no. For cancellous bone, you may or may not.
Yeah, I have one comment regarding
yeah.
this.
Yes, sir.
Yeah, about the pre-drilling. Usually, what we do in our practice in metaphyseal areas, we just make a small hole in the cortex with the drill, and the rest of the bone we don't use the drill. Then because to avoid fractures, it's always better to just maybe 3-4 meters just to make a hole in the first cortex, and then you can easily put your pin throughout the metaphyseal area without doing the pre-drilling. But yes, in cortical bone, it's always better because lot of heat also will be generated. So yes, in the metaphyseal area, you can easily do that. And one thing more about that tendons and the muscles. See, the atlas which is usually we follow is based on the neurovascular structures. But when we are applying a wire, it's always better when we rotate the wire through the drill. It's always better to rotate only through the skin. Once you enter the skin, you have to push the wire. You don't have to use the drill, and you have to feel the bone. You can easily feel the bone with the tip of the wire without rotating. And once you have felt that your wire tip is properly on the bone, is not in any muscle or tendon, then you can start again rotating. Never rotate the wire when you are in the space between skin and the bone in the muscle area. If you follow this, you just push the wire manually without rotating, then most of the times you will be able to save tendon and the muscles. So that's a small trick you can do in your practice.
Sir, just to add to that, sir, once we reach the far cortex, as the wire is just out, we can simply tap it. It will reduce the chances of impaling any tendon or any other vital structure. As you said, sir, just adding to what you said.
So we'll move to the next talk, that is case presentation, and that is by Dr. Ritesh Runu. And Dr. Ritesh Runu is a professor at IGMS Patna. Sir, are you there? Ritesh, sir? I think, has he lost contact with us? So if
Meanwhile, I will answer there's a question in the chat that whether even in closed fractures, do you do Ilizarov? So my suggestion for the beginners that when you do both plating and Ilizarov for fractures, when you are used to both the techniques, many times you feel that if there's a lot of combination or the skin is that bad that it will take a lot of time to heal, you can definitely go for Ilizarov. But yes, for the fractures which are extending to the joints, you have to have proper reduction. There's no other way around it. But if it's a metaphyseal fracture, many times even in cold fracture, if it's very committed and the skin is bad, we go with Ilizarov, provided you know the technique proper. And I always suggest that you should be knowing both the techniques. Then you can choose unbiased what you want to do for the patient. Many times you know only plating, many times you do only Ilizarov, then it may be a little biasing. But if you know that both the techniques comfortably, you can always go for any one of the techniques depending on the patient.
right. So I'll be sharing the next case. Am I audible and is my screen visible?
Yes.
So I'm Dr. Jaswinder. I'm from Patna. So this is just a small and a simple case. I'm not showing anything very complicated. So this is a case of a sequel of distal femoral osteomyelitis. So this in 2020 during the COVID time, this patient had presented to us. He's 4 years at presentation and he had a history of osteomyelitis. That is, there is some infection around the knee, which was treated conservatively. And the X-ray showed that there were features of osteomyelitis. So it was treated 1 year back conservatively. At presentation to us, he had normal lab investigation. The ESR CRP was normal, the counts were normal, and on clinical examination also there was no sign of active infection. The knee range of movement was almost full. The problem was that his father said that he has a shortening of right lower limb and with a deformity. And we calculated the deformity. It was a 35 degree of distal femoral varus deformity. And then there was a shortening of 5 centimeter. I don't have the pre-operative clinical video of his walking. I could not find it. I did have it. So this is what was the scanogram. So there was a 35 degree of varus of distal femoral. And there was a shortening on the skeletogram when compared to the opposite side of 5 centimeter. So may I ask from the panelist is like, how would you like to approach this case from him? Rajat sir, Dr. Ritesh, and Shamsul.
So this is here we can see there is a physeal bar actually in the distal femur, most probably due to the infection. And because it is post-infective. It's not post-traumatic and is involving a big area. Actually, I think it's more than 30 to 40%, more than 50% of the physis is involved. So bar excision is not an option here in my view. I will go for a deformity correction and maybe stapling on the medial side so that it doesn't recur. And
So stapling on the medial side will cause further growth on the lateral side and it will increase the varus.
on the lateral side, sorry.
Oh, right.
And then dealing with the shortening at repeated intervals.
So why wouldn't you like to address the bar excision here?
So first I will like to get the exact area, how much it is involving. And it is said that if more than 30% of the physis is involved, then it doesn't have good prognosis. Means you are
So
already
how will you look for that bar? Any more investigation do you want?
CT scan. So mapping of the physis. We
Yeah,
need to
I mean through any investigation, particularly
CT scan, CT scan.
CT scan. Okay. So so we got a MRI done, and that is MRI at that point of time. Dr. Ritesh, I think you are muted.
Yeah. So here do you have the axial cuts?
No, I'm sorry. I have only this MRI pictures. I don't have any other.
So I think
So,
this is central bar and
yeah.
the medial and lateral physis both are spared as seen in this figure, the first one. So one can give a try of bar excision in this case. Means
Right. So the bar was near about, we would say 40%. And then this is a contralateral or horizontal bar. I'm sorry, I'm presenting a pediatric case because I do pediatric, I deal with the pediatric cases also. So as Dr. Ritesh said, this is a central bar, the medial and the lateral side were spared. But the problem is it is near about 40%, and then we don't know how much it will work. One second is there is adequate amount of growth left. For the bar excision, there should be a minimum of 2 years of growth left. And the third is it is a progressive deformity. From last 1 year, it has progressed to around 35 degree of varus. And then the fourth thing to consider is that there is also shortening. Even if we excise the bar, of course, there is a chances that there will be growth along with the whatever lengthening we do. The problem is this, as Dr. Ritesh mentioned, this is not a traumatic bar. The traumatic bars, usually they behave differently from the post-infective bar. So in the post-infective bar, they are basically sick physis, and even whatever the best work you do, you can still expect it not to work very well. So, and we were not very confident with the bar excision because it being a central, the peripheral ones are considered better. So we went ahead with the plan of that we will not touch the bar, will not do the excision, and the rest of the plan, as Dr. Ritesh Pandey just mentioned, we wanted to put a plate, temporary epiphyseal disc is 8 plate on the lateral side of the distal femur, so that as with growth, whatever is growth is there, the deformity corrects from the varus to valgus. And there was a significant shortening of 5 centimeters. So we wanted to correct it with distraction osteogenesis. So this is what we did. We did a distal third corticotomy, and we put an LRS 3 pins above and below. And that was a lateral picture, and along with the lateral epiphyseal discs. And that's it. That's a AP and lateral picture, and that is how it looked on table. So are you convinced, Dr. Ritesh, or any other panelists who would like to add something more to this?
yes, this looks all right. The only thing is that the osteotomy is far away from the cora. So if we could have done the osteotomy a little distally,
Right.
this primary deformity could have been avoided. So.
Right. Thank you. So at the end of the, I mean, this was on table correction. We got the joint almost to horizontal, and and then we had a plan to lengthen it in the coming days. It being a 4-year child, it was not a concern of that it will go to, I mean, non-union with this much of correction. So at 2 weeks, that was the distraction. With the distraction, we had an X-ray. And Are you happy, Dr. Ritesh again? Any concern or anything?
It looks all right.
Okay, right. So that is at 3 weeks post-op. That is at 4 weeks post-op. And that is at 6 weeks. So we were concerned that it is being lengthened, so he might lose movement also. And that is why we were quite strictly following that he has 90 plus movements. There is some extension lag and near about 4.2 centimeters were lengthened. And that is at 5 months. And at 5 months, one pin on either side were removed. The LRS was dynamized. And I see if this works. So this is how he's actually walking with. There appears to be some deformity at the foot, but as such, there is no fixed deformity. It's just because of that LRS he's walking like that. So the bone is also forming quite well, and that is at 6 months post-op. Again, further dynamization, only one pin left on either side. So any more comments? Are you happy, Dr. Ritesh?
Yes, I am happy.
Okay, right. Sorry.
Sir, Dr. Jaswinder, how about his knee movement? Has he gained it?
Sir, he had good movements. He had always 90 plus movement. I would say 100, 110, I would say.
So could you make a difference if you had done a TFL, kind of a cut in the TFL while lengthening the femur, maybe?
Usually we don't do it routinely. I'm not sure what other panelists follow, but we do a lot of lengthening like these and more than these. But usually,
This looks like around 5 centimeters. Almost.
Yes.
So he's a kid. I think it's a huge amount for him. It's almost about 20% of his entire femur. So
Right.
that's my view. I mean,
So you want to cut it kind of transversely, horizontally?
Yes, horizontally.
Okay.
Yeah.
Right.
And just over the suprapatellar region.
Right. So
Just
that
my take, sir. I think it might have ended up with a better knee movement if he's not got a full knee movement.
sure. And just recently had sent his X-rays. He's not ready to come. He got the LRS removed at that time only, and then he disappeared in near 2021. And he still has the plate intact. The plate as such, if you see, is not working very well because again, there is some varus, maybe around 10 degrees. He has also got some shortening. Incidentally, he got an X-ray done on my advice and then he realized that there is still a plate. So he might come for a follow-up, but these are his clinical pictures. As such, he does not have any complaint. And that is the reason he might have not thought of following up with us. He might come in the near. So that is all what I wanted to present. A little different from just a simple lengthening. Thank you.
Yeah, so Dr. Jaswinder, I can see this plate is still working well, I think. The small amount of varus which has appeared, I think that is due to remodeling of the osteotomy site.
See, the problem why I say plate is not working well because the screws have not diverged. Ideally, the screw, it has backed out a little bit maybe, but for it to work quite well, those should have gone in those directions,
No, but it will diverge only when the medial side of the physis is growing. So that is already damaged and diseased. So unless the medial side is growing, these screws will not diverge. It will just avoid the growth on the lateral side. And the valgus which was given at the osteotomy site, we can see that it has very nicely remodeled. And that could be the reason for the varus which has appeared again. And so that is my view.
Right. So
I would like to comment. Yeah, but it was a very unique combination of doing a lengthening and applying an 8 plate also. Yeah. The only thing that since this was a 4 years child, so the osteotomy was done a little above, and there was no compensatory translation was done as we follow in Rule 2. But this was perfectly okay with this case as a 4 years old child, and a perfect remodeling was done. Yeah, very nice combination and best in the
Very nice.
presentation of it. Yeah.
So next, if there are no more questions, we'll go with Dr. Ritesh Runu's sir's case. Are you there available, sir? Are you available there?
Yeah, good evening to all.
So, Dr. Ritesh Runu works as a professor at IGMS Patna, and over to you, sir, for your next. Please share your slide.
Yeah, thank you. Today evening, I'll be sharing a case where we used LRS and it's as a novel tool for infected non-union of the femur. Yeah, next slide, please, Dr. Shamsul. In September 22, we got a case reported to us with a painful swelling over his right thigh and hip and following nailing of the right femur, only 8 days post-operative in a 55-year male. He had closed femoral shaft fracture, a compound fracture of the right tibia and fibula, and displaced tibial condyle fracture 11 months ago before the patient presented to us. And he had no neurovascular deficit. The initial treatment in this patient, next slide, please. Yeah, next slide, please. Here you can see that the patient had fracture of the femoral shaft with large butterfly fragment displaced. He has a fractured tibial shaft and fibular shaft fracture along with tibial condyle fracture. A very severe high velocity trauma due to RTA. This patient was managed elsewhere with IM nailing of the femur and plating of the tibia. Yeah, next slide, please. Here we can see that the nailing has been done and butterfly fragment is still away. Means it was a closed nailing along with fixation of the tibia. Next slide, please. 5 months after the injury, due to some infection, the nail was removed and external fixator was applied in the femur along with external fixator in the tibia and plate over the tibial condyle was kept. Next slide, please. 10 months after the injury, once the infection healed, I think we for definitive fixation, all the fixators were removed, all the plates were removed. And after this, the patient shifted to some other doctor where in 11th month post-injury, IM nailing was done. Next slide, please, Dr. Shamsul. There we can see that IM nailing of the femur has been done, cephalomedullary nail, and large butterfly fragment was removed. Along with nail, there was a plate applied over the femur, but only 8 days after the operation, the patient developed high-grade fever along with all the signs of infection. And the patient has severe pain. Next slide, please. And the patient presented to us. So we planned for removal of implant along with debridement and use of biocomposite along with antibiotics. And our aim of treatment was to achieve infection control, union, and after that limb length correction and functional recovery. But during removal of the plate, the patient went in shock and the surgery was abandoned. The patient was shifted to surgical ICU. Next slide, please. Here we can see that this was the scar, post-operative scar. Patient recovered in 2 days. He was kept on antibiotics and the culture report came out to be Klebsiella pneumoniae and it was resistant to all the antibiotics. Next slide, please. The patient was sent home with the nail in situ, but within a month, patient again reported back with swelling in the thigh with pouring pus to the medial wound and lateral wound, and therefore we decided to take out the nail and we reamed the femur. But during this procedure, again the patient had some problem. Next slide, please. And the patient, we took out the nail, but the patient developed cardiac arrhythmia. Therefore, we simply kept the patient on Thomas splint along with traction and dressing was done. After a month, when the patient recovered, we applied the LRS in the femur. We didn't touch the tibia. The knee was already stiff. So the infected fracture site was opened up. It was refreshened. LRS was applied and we can see that we were unable to close the wound primarily. So we kept it open for regular dressing. Next slide, please. The patient was on regular dressing and compression was started over the fracture area And within 2 months, we can see that some callus formation started over the fracture site and wound also started healing. But during this process, the patient had regular cardiac arrhythmias. You can see that his pulse rate used to go. Many times he had atrial fibrillation. Next slide, please. 2 months post LRS, wound healed better and the patient started walking. In the video, we can see that the patient is video is not running. No problem. The patient has started walking on walker, and 7 months post LRS fixation, we can see that hypertrophic callus was there, but there was no bridging callus. And due to loosening of the pin, we had to change the pins in the proximal fragment of the femur, and there was 3 centimeters of shortening with a stiff knee. Since there was lack of bridging callus, we plan to start the accordion maneuver. Next slide, please. Since there was a lack of bridging callus and lot of proximal and distal fragment was having lot of callus, so started accordion principle and alternate distraction and compression was started. Next slide, please. Accordion maneuver is already a well-known maneuver where in case of poor regenerate or in case of hypertrophic non-union or in atrophic non-union, to get the callus formation, to change the scar tissue and to regenerate the osteogenic potential in the scar tissue, we go for alternate compression and distraction maneuver. Next slide, please. So in our case, we followed the protocol of distraction of 0.25 mm 12 RD for 7 days, followed by rest of 3 days, then compression of 0.25 mm 12 RD for 3 days. So like this, we followed it, and 1 cycle of distraction, rest, compression, and rest makes 1 cycle. So similarly, we had to go for 5 cycles. And after that, in this next slide, probably video is not working well. So we started dynamization, and at 13 months post LRS fixation, we can see that we had a good bridging callus. And then we decided to remove the LRS. Patient was standing well with walker, and he was kept on ischial weight bearing caliper. And he started walking on ischial weight bearing caliper. Next slide. So in this case, we can see that the pain was nil. The patient was able to bear weight on his right lower limb. The bridging callus was present on X-ray. The regenerate or the callus which was formed was dense. There was no radiolucent zone within the callus area. Therefore, we removed the LRS. Next slide. And 20 months post LRS, we can see that the patient had good united femur with stiffness of the hip and knee. And by this time, tibia has also united well. And in this slide, next slide, 2 years, 10 months post injury, the patient is able to stand and bear weight. The slides, videos are not working. And this is the latest photograph of his leg, where he has reported that discharging sinus are present over his leg, over the tibial fracture area. So according to Asami, if we see the next slide, please. According to Asami, if we see the bone results, the bone has united. The sign of infection in femur was not there. Deformity was less than 7 degrees, and limb length discrepancy was 1 inch around. So the results were fair, while in the functional results were good, because the patient was active with the limb. He had a stiff knee, but no RSD and no significant pain. So we can see that, next slide, please. LRS is a good device in cases of infected non-union as a primary stabilization tool as well as a definitive tool also. And it has a versatility that according to the situation, we can change the construct, we can apply new pins as and when required. An accordion technique as we use in Ilizarov, we can also use in LRS. And it should be done judiciously, not too fast or not too slow. And in these cases, patience, peace, and prayer helps in good outcome. Thank you. Any questions, please?
Thank you, sir. Very complicated cases, because most of the time we don't think of the systematic factors. We always think of only the orthopedic problem as like the body as only the orthopedic parts. But yes, see, to manage everything and still getting out with the final good outcome is a wonderful case. Yeah. Only thing, are you planning to do anything for the tibia varus later on if it increases or if the infection doesn't subside later on?
Yeah, the patient for the stiff knee, we are planning for total knee replacement later on once infection subsides. And for tibia, we have asked the patient to come for sinogram. And if there are any sequestrum present in that area, we need to remove that. And the tibia has already been multiple plastic surgery has been done. So the soft tissue condition is bad in that area as well as in the thigh also. So any major surgery we are not planning, but for discharging sinus, we need to remove any sequestrum present there.
Okay, sir.
So, sir, what was the sequence of compression and distraction? Is like
Yeah, it is variable depending upon the condition, as Dr. R.K. Barua has stated in his paper, that in case of hypertrophic non-union, he has started with distraction first for 7 days, followed by rest, and then compression for 7 days and rest. And in cases of atrophic non-union, he has suggested to go for compression first, followed by distraction. So the cycle of distraction and compression can be used according to the situation. In our case, since it was a hypertrophic non-union, we went for distraction first, followed by compression. And we had to use 5 cycles. We should not remove it, go for fast forward mode. Depending upon the callus formation and union process, we should keep on doing it.
Sir, I have a small doubt, not a doubt, sir. We know, as we have been taught about hypertrophic and atrophic non-unions, that hypertrophic non-unions are basically a marker of maybe some instability, sir, relative instability. So should we not focus more on providing additional stability to the construct and allowing the patient to weight bear and walk, so that, rather than going for an accordion maneuver, which is mainly adding to the biology?
Yeah, Dr. Mahesh, that I have shown in this presentation also. Before going for accordion, we have changed the pins in the proximal femur, which were loosened. And that was one of the factor for hypertrophic non-union. Lot of callus formation was there, but no bridging callus was there. But at the same time, you can see that in 2 or 3 series X-rays, the bridging callus was not appearing. So we have changed the pins first, made the frame stable, followed by accordion technique, because it also fastens the healing process. Otherwise, it may take a longer time.
Correct. Thank you.
This is very important point we should keep in mind, that hypertrophic non-union first make the frame stable instead of trying to do anything else. Yeah.
And one thing, sir, usually I have seen very rarely in cases of infected non-union going into hypertrophic non-union. Usually hypertrophic non-union are caused in which there is a problem of stability and the patient lands up in hypertrophic. But this is a good case, like in case of infected non-union also, there was ultimately hypertrophic non-union.
Yeah, it can be due to a change in the biology of the high of the fracture area, because due to persistent infection, many a times the blood vascularity is diminished due to multiple thrombosis of the vessels. And if those thrombotic vessels are removed by debridement and the vascularity of the area increases, the callus formation will increase in these areas.
Sir, in infected conditions, even the pull-out strength of the pins will get reduced. So it will eventually lead to an instability around the docking site.
Yeah, definitely.
It's a
And
debate.
especially in the patient who is not walking, the bones become osteoporosed very fast.
Yes.
Therefore, in our case, we asked the patient to start walking immediately after the operation as the patient pain conditions improve.
Ritesh, sir.
Yeah, Dr. Shamsul.
Sir, regarding the stability, just like to add, can we not apply 4 pins proximally for added stability? We could see 3 pins only in 2 clamps. So we can add 2 pins each in clamps, or if you are applying a Ilizarov, we can give an add-on iliac stability rings or arches. Rajesh, sir, your take on that, sir?
Actually, I don't go for iliac stability because fixing the hip joint is not a very good option.
Right,
But 3 pins is also actually depends on the case to case. If you can feel that the pin are a little loose, maybe because of infection, then you may add up. But usually, as the literature says, 3 pins are sufficient. But to have more satisfaction, you may go for 4 pins, but the proximal fragment is a smaller fragment. To add up the 4th pin, it depends on the case whether you can easily add up the 4th pin or not.
right.
Actually, I have another question, sir. That you said
Yeah.
you removed the LRS and you applied ischial sparing brace. So didn't you went for the gradual dynamization, or you went straight away to the ischial sparing brace?
Gradual dynamization was already done. It was shown in this video also, but videos are not running. After dynamization, once we got the good callus formation and patient was able to bear weight, then we went for removal of the LRS. But the patient was kept on ischial weight bearing because of a small proximal fragment, and this was a type of just a weight, not completely weight relieving, partial weight relieving caliper, just to support the patient and make his confidence bit higher so that he is able to walk without any support.
Okay.
So that is very essential. Before removal of the frame, we need to make the patient stand. We need to check for his pain, able to bear weight, and at the same time quality of regenerate or the callus which has formed around the fracture site. That is very essential.
Yes, because in earlier case also we saw the case in which only 1 pins were left in the LRS above and below. But that's also one of the options, that you keep on decreasing the pins, and even with 1 pin, when the patient is able to walking for 1 or 2 months, then you can comfortably remove the frame without even applying the brace. But yes, this was a very small proximal fragment and a very bad case. So it's always better to go for more precautions and go for a partial weight bearing brace. Yes. Thank you.
Yeah.
Dr. Jaswinder, there is a question in the chat box. Jaswinder.
Yeah, there is a question. The question is, instead of accordion, adding more compression would help more in this case for early union, sir. So that is more of a advice actually.
So that we can see that for 7 months we used the compression device, compression mode, but the callus formation was still not sufficient. So once we get that for 3 months or 3 or 4 months, on repeated X-rays, the callus formation is there, but bridging callus is absent. So in those cases, we need to consider about accordion principle. And second is only compression will add to the shortening of the limb. So at the same time, we have to see that shortening should not be too much, that we need to go for corticotomy and lengthening later on. And plus, accordion principle also helps in early healing of these type of fractures or non-unions.
So if you don't have any more questions, I think we are left with the last case presentation by Dr. Ashutosh.
Yes.
Ashutosh, will you be sharing your screen or shall I do?
Yes, sir. I can share my screen.
Please do, please.
So
Yeah.
we have another 10 minutes left for this whole meeting. So I think we should be in time and we'll finish on time.
Hoda sir, please share my PPT.
Acha, you're not sharing. Okay, I'll do.
Yeah, this is my case. Management of coxa vera by Ilizarov dissector followed by DHS splitting. Is it full slide?
Can we make it full screen?
Dr. Ashutosh, is it a PDF? Is it not a PPT?
Okay,
Do you have the PPT you can share? This is the PDF that you shared me.
just 1 minute, sir. Yes, sir, I have a PPT.
Please share.
It's okay.
Please share.
Yes. Management of coxa vera.
We cannot share your screen.
Yeah.
Please do.
By the Ilizarov dissector followed by DHS splitting applied. 15 years.
Screen. Please share your screen. We cannot see your screen.
A 15-year male having history of trauma 5 years back was
Wait. Can anybody see the screen or not? Ritesh?
Yeah, it is visible.
We can see it. We can see it.
Okay.
Yes. So 15 years male having history of trauma 5 years back was treated conservatively for hip injury while CC screw apply in the hip joint. Patient came with limping gait and shortening of the right hip with stiff knee. So on examination, patient has limping gait with shortening of 7 cm. Neck shaft angle is 90 degree. Range of motion hip 0 to 100 and knee is 0 to 10. So we plan to treat with Ilizarov Italian arc. So we had applied the 3 Italian arc, one at the level of pelvis and 2 in the femur. So 2 Sanspin at the iliac crest level of the ASIS and 1 in the anterior inflexible spine. 1 Italian arc is applied at the pelvis and 2nd and 3rd is applied in the femur with 2 Sanspin and Italian arc. So sequentially, I started the sequentially dissection at the hip joint, done at the 0.25 mm 6 times a day, as there was the shortening of 7 cm. So we get the limb length equality in 1.5 months. So after complete dissection, the arc is left for 3 weeks to prevent the gluteus medius to pull. So after 3 weeks, Italian arc is removed, followed by abduction osteotomy done and DHS plate applied. Patient kept for non-wet wearing for 6 weeks, followed by partial wet wearing. After 3 months, patient is walking full wet wearing with equal limb length. Thank you. This is my short case.
Any questions, please?
Yes, Dr. Ashutosh, this is a very nice case. So as we can see, this is more of like a delayed union of intertrochanteric fracture, right? Causing coxa vara.
Yes, sir.
So were you able to correct this varus deformity by distraction with Ilizarov?
Sir, we get the limb length. We not able to completely collect the varus deformities. So around 190, it's around the neck shaft is 90 degree. We achieve around 110, sir. After that, we can't able to, but the limb length was almost equal. So we plan to do the DHS abduction osteotomy followed by DHS at the same sitting.
Okay, because here I can see the neck shaft angle is even less than 90 degrees. It is somewhere around 70, 80 degrees in this figure.
Yes, sir.
It was brought down to 110 degrees and the residual was corrected with valgus osteotomy, right?
Residual was corrected with valgus osteotomy. That I had done after doing the destruction. The limb length comes almost equal, but whereas we can't able to correct the varus deformity. So we plan to do the.
I'm just trying to figure out, like, can you share the previous slide?
Sir.
Before this?
Sorry, हाँ.
No. वो जो फिक्सेटर के साथ.
First one.
Yeah, this one. So
Yes, sir.
even in this slide, the neck shaft angle is looking same, no, around
So
7.
just after applying the, sir, this is arc, just after applying the arc.
Achha.
After we had
Fine.
done the destruction, so it's the last. We cannot able to take the proper X-ray. We can see here. To some extent, the neck shaft angle is decreased, but not we can't able to completely correct the. So we had planned to do further with the DHS.
Ashutosh, I want to ask one question. That
Yes, sir.
this was the 5-year-old injury.
Yes, sir.
Patient presented with coxa vara. It
Yes,
means
sir.
the fracture side, everything has healed around the hip joint.
Yes, sir.
So with the healed neck shaft angle,
Yes.
how we are able to get a correction?
Sir,
With,
there was I had not get the correction. There was this pull of the gluteus medius. So I have trying to get the reduction, get the neck shaft angle reduced. But along with that, I got the pulling of the gluteus medius also, sir. So that after we had later I had planned to do the DHS so that it can't get failed.
okay.
Yes.
No, we are just trying to figure out like what did we achieve by putting Ilizarov and distraction, because the head is not moving anywhere. No, it is remaining in the
You
hip
can see
joint.
that after sequential destruction, we are getting the limb length almost equal. So after getting in 1.5 months, we had got almost equal limb length. So around it was the 7 centimeter shortening. Later on, we get around the 1.5 centimeter shortening in left.
Achha. I just wanted to mention that we could have gone directly with a valgus osteotomy rather than doing it in.
But yes, I had done directly the valgus osteotomy. The patient have a persistent lurch. So due to the other, maybe the possible of the pull of the gluteus medius or something might be, but in this case, I had got the complete limb length, and there was no shortening after that.
Okay.
Right. So if we are through all the cases and no more questions, then we can come to the conclusion of the meeting.
Stop sharing. You can stop sharing.
Yeah. So may I ask Dr. Rajat sir to conclude the meeting, and if there are some additional remarks to make from other faculty.
Yeah, so I think the most important thing that these were the cases which most of the orthopedic surgeons they get in day-to-day practice. And what I felt with this whole webinar, that other than the talks, the cases were so important and the discussion was so good that when we'll be hosting this in the Asami YouTube and many of the youngsters will be seeing the cases, so they will be benefiting a lot. So yes, I got this input that in the next webinars also we'll be focusing more on the case presentations, and I think that's very important. And we all had a wonderful case presentations. So congratulations to the speakers and thank you that you all spared you personal time, and this is for the benefit of all the youngsters. I think they will be learning a lot throughout. And thanks again. And if any other faculty wants to make a remark, please go ahead.
Yeah, I want to thank Asami and all our participants and our organizers, Dr. Jaswinder, Dr. Ritesh, Dr. Shamsul. And this was a very informative regarding the basic principles of Asami, basic principles of LRS and Ilizarov fixation. And I hope that this will help in youngsters to do good surgeries. Because many times missing basic things may lead to a lot of complications. Thank you. Thank you all.
Thank you, sir. So see you all next month with the Tamil Nadu chapter of basic series. Thank you all for coming. And we also welcome you all for the coming AsamiCon 2025 at Chandigarh. With this, we are ending this week's show. Thank you and good night to all. Thank you, sir.
Good night,
Thank you.
everyone.
Thank you. Thanks for
Thank you.
being on time. So good night. Thanks, everyone.
Yes, sir.
Thanks, sir.
Yeah, we can stop. Fine. Yeah. Maharshi, please end.
ये बंद हो गया.
अभी नहीं हुआ. Live streaming. Maharshi, please stop live streaming.